Welcome to the renal tract ultrasound module for the WACS ultrasound training. I'm Dr. Casey Parker. This is the template which should be attached to the ultrasound machines in your area. We won't go through this now, but this is a good system for looking at scans and looking at the important things that you might want to include in your report. Let's start with how to actually do a kidney scan. So kidney scans can be a little bit tricky. The variable position and different anatomy makes it a little bit hard to see the same on every person. It can be really useful to get the patient to take and hold a deep breath. What this does is pushes the liver and spleen down and creates a nice acoustic window for you to see the kidneys through. You can also roll the patient onto the side, and this allows a posterior approach, which is sometimes useful scanning up through the psoas muscle to get away from the bowel gas, which often obscures the front of the kidney. It's quite common to have rib shadows, and these can be very annoying, particularly when you're trying to take a long view of the kidney. However, it is acceptable just to take multiple pictures with rib shadows, as long as you're happy that you've seen the whole kidney in that process. The recommended protocols that you scan through in trans from upper, middle, lower, and once again, you always scan all the way through an organ, right off the edge, so you make sure you're not missing any interesting lesions at the edge, and then in longitudinal scanning from anterior through to posterior and focusing on the hilum, which is where you're going to see a lot of the pathology. The only thing we really recommend that you measure is to measure the longitudinal length of the kidneys, and you can compare one side to the other. It can give a clue as to when something maybe isn't quite right. These images come from a great website called sonographictendencies.com, and there's some great videos on there that explain how to scan things. Really useful, recommended viewing. So let's talk a bit about the normal sonographic anatomy. Kidneys are bean-shaped, like kidney beans, and they typically have a hyperechoic hilum, which is usually full of fat, and when you get it on the right angle, you can see the calyces coming through the hilum. There's the major calyces, and then the small sub-branches, the minor calyces. The medullary pyramids are hypoechoic, darker structures that point into the calyces, and then the cortex is a little bit more hyperechoic than the pyramids, and that sits around the outside. Now, the whole kidney is encased in Gerota's fascia, which is a thick fascial plane, which is not normally visible, but when there is fluid between the kidney and the fascia, you may be able to see that. The ureter is not typically particularly visible once you get past the renal pelvis. It's usually collapsed, but if you're seeing it, then it's probably abnormal. Now we'll talk a bit about bladder scanning. So bladders are generally easier to find. We tend to recommend that you try and scan bladders with them full, and then we usually do a post-void calculation as well. So in trans, put the probe just above the pubic bone in transverse and identify the bladder, fan through from top to bottom, and try and freeze on the biggest part of the bladder that you can find. We traditionally measure the depth and the width in this plane, and then you rotate the probe 90 degrees, looking over the top of the pubic bone, trying to see the bladder in its full length from the dome right down to the urethral outlet. Now, this is meant it's easy to identify because of the prostate, and you take a measurement there. Our machines have calculation packages in them, but the actual volume calculation of a bladder is a little bit controversial because it's not just the depth, width, and length. It's not a cube. It's usually an ellipsoid shape or sometimes a trapezoidal pyramid, and so you need to be aware that this is all then multiplied by a fudge factor, and different calculators use different fudge factors from 0.52 up to 0.78. There's lots of different ones. It doesn't really matter as long as you're aware that it's not a perfect cube. Now, the residual volume is typically less than 100 and often much less than that, and in kids we say less than 10% of the opening volume. Now, it's important when you're measuring post-residual volumes to make sure that you're actually measuring the bladder, because the bladder can get very small, just a centimetre or two in diameter once it's been properly emptied. And you may need to fan your probe right down under the pubic bone to try and see a very small bladder, and that can be particularly hard, particularly if there's a lot of bowel gas around. There is a bit of a pitfall in that there's other things in the pelvis that can get the appearance of a bladder and can sometimes get measured, and classically this is an error that the old blind bladder scanners that the nurses use on the ward tend to make. So things like large ovarian cysts, free fluid, or even a bit of bowel obstruction can fall down into the pelvis and mimic a bladder. So just make sure that what you're looking at is in fact the bladder before you go about measuring it. Here's a great picture of a very small bladder hiding up in the corner of the screen and this large adnexal cyst, which could by all means look like an abnormal bladder. Now, identifying ureteric jets is not particularly difficult, but does require a bit of patience. So the easiest thing to do is to get a transverse view, identify the urethra and the trigone, which is a triangular structure on the back of the bladder, fan just posterior to the urethral outlet, and that's where the ureters usually are. Now the ureters come in on a bit of an angle of 20 or 30 degrees off of the transverse axis. So you try and line that up, hold your probe really still, and then you just wait. And you're waiting and waiting. You're waiting for a jet, which you see on color flow Doppler. So with a color box situated just over the base of the bladder, you're waiting until you see the jets. Now sometimes you see one, and then you wait a little while and you see the one on the other side. Sometimes you get lucky and see them both at the same time. But generally you need to wait for a minute or so before you can say it's not there. And sometimes it can be really useful to hydrate the patient first just to make sure that there is a lot of fluid in the bladder. They can also be quite tricky to see if you've got a very empty bladder. So you need a bladder that's at least moderately full first. Now, when you're waiting for ureteric jets, it's really important to have your non-dominant finger hovering over that freeze button so that when you see the jet, you can freeze, catch it, or cine back a few seconds, get that nice picture, and then record that. So here's an example of an abnormal bladder. So this is a longitudinal shot of a 70-year-old man that's having difficulty passing urine, and this is a post-residual picture. So you can see there is quite a large volume of fluid there, probably a few hundred mils by my eye, and there's this large structure sitting down at the base of the bladder, which is of course the prostate gland bulging into the bladder. This is quite significant prostatomegaly, and this would be one where you'd think this could be a difficult catheter. I might need to take my time on this. And certainly it can be really useful to use ultrasound to guide catheter placement in this setting if you need to do it. Here's another example of an old chap. This chap's on warfarin. He's been unable to pass urine. He's got a lot of hematuria leading up to this, and this is a large hematoma or clot within the bladder which is causing clot obstruction. And if you see this, then you know that it's not going to be possible to drain with a simple Foley. You're going to need to place a 3-way and do a washout in order to get rid of that clot from the bladder. And just a trap for young players, these aren't that infrequent. This is a large bladder diverticulum. So we have the normal bladder here labelled UB, and then there's a small neck and a large diverticulum coming off the posterior wall of the bladder. And this can be a trap for young players. It sometimes looks like just a very large bladder with some weird folds in it, but this is actually a diverticulum. And if you put colour on the neck there and bounce it, you'll see the urine sloshing back and forth through that opening. These are often asymptomatic, but can be the source of urinary tract infections. Another trap for young players. Here's a 45-year-old septic diabetic patient who's in the HDU. She has had no urine output after a Foley was placed. And unfortunately, as you can see here, there's a nice full bladder. And just posterior to the bladder, you can see the nice circular balloon of the Foley, which is unfortunately in the vagina. Now, this is what we're really looking for when we're looking for kidney stones. So kidney stones can be quite difficult to pick, and the common places that they lodge are up at the PUJ, at the VUJ, and sometimes at the pelvic brim. And here is an example of a hyperechoic shadowing lesion at the right VUJ. And one of the tricks that you can use to make them more obvious is to put a color flow box over the VUJ. And stones have this unusual physical property where they create what's called a twinkle artifact, which looks sort of like a chaotic blue-green, sometimes red signal that bounces off the back of the kidney stone. So if you see that, then that's probably what it is. It makes it easier to draw your eye to those little stones. A couple of other weird things that you may see in bladders. On the left, we have a heavily trabeculated bladder. This is commonly seen in patients that have bladder outflow obstruction, such as prostatism. Can look like small tumours, actually, but these are actually just deep folds in the wall of the bladder with the detrusor muscle poking through. So that is a trabeculated bladder. And then on the right, we have a couple of TCCs. So these are small exophytic tumours which grow into the bladder wall. There's often more than one, and if you put colour flow on this, they may have colour flow within them. All right, let's move on to kidneys. Now this is the right kidney and longitudinal with some liver in the foreground, and this is very subtle, but there is some slight hydronephrosis that you can see the dilated renal pelvis and maybe some of the smaller calyces coming through. So this makes you think what else could be going on here. Ureteric obstruction is a really hard call to make. We don't often see the primary lesion, so we're looking for secondary signs of obstruction. And the two common ones are the absence of a ureteric jet on that side and hydronephrosis. Now sometimes we get lucky and we actually see the stone or the tumour or the clot or whatever it is that is actually causing the problem. But you need to be aware there are a few traps for young players here. Obstruction in a patient that's oliguric because they've been up all night vomiting with their kidney stone will give you no hydronephrosis. You need to have a decent urine output before you get hydronephrosis. Incomplete obstruction from a stone or a tumour, you will still see a jet, but often it doesn't quite look right, or it looks quite diminished compared to the other side. And sometimes we see what's just a constant trickle of urine rather than discrete nice boluses of jet coming through. If you take a young woman and completely overfill her bladder in the process of trying to achieve your scan, it is possible to create mild hydronephrosis, and that'll go away when you empty the bladder. And pregnancy, of course, can cause mild to moderate hydronephrosis, usually after about the 20-week mark, and it's more common on the right than the left. So don't be too surprised if you see a little bit of hydronephrosis in the pregnant women. There are a few things that do look a bit like dilated renal pelvises or hydronephrosis. I'll just show you some examples of those now. So the first one, the top right of screen there, is a extrarenal pelvis, and this is just a anatomical abnormality that some people have where the pelvis of their kidney sits outside of the kidney stroma as such, and so you see this often on the transverse image, and if you go back and look through old scans it'll look the same. It's not a dynamic process, it's always like that. Renal veins can certainly look like hydronephrosis if they're a little bit distended, or if you catch them in just the right angle. The trick is to put colour flow on and make sure it's not a vein, which is the top right. And then the bottom right, we have what looks like there probably is a bit of hydronephrosis, but there's also a cyst just adjacent to the pelvis, and this is a normal benign looking kidney cyst, but when they're right next to the pelvis it can look like a dilated pelvis. If you look really closely though, you won't be able to connect the cyst to the connecting system. Alright, so here's that same image I showed you before. This is that kidney that had that subtle hydronephrosis dilated of the renal pelvis, and if you look closely now on the right, just as the ureter's exiting past the inferior pole, you can see a hyperechoic shadowing lesion, and that is a stone. So that's causing some obstruction. And if you put colour flow, you'd probably see a twinkle artifact coming off the back of that. So stones can be tricky, but it's worthwhile having a look if you've seen what looks like hydronephrosis. This is an example of some more moderate hydronephrosis. So in this case, there's clearly dilatation of the whole collecting system. You can see here that the calyces are starting to club into a sort of a convex shape. So this is definitely moderate degree of hydronephrosis. The actual cortex of the kidney looks relatively well preserved. It's over 10 millimeters. And so we'd probably say this is moderate rather than severe. Severe hydronephrosis requires some thinning of the renal cortex. And here's an example of a patient that has congenital pelvo-ureteric junction obstruction. So this is a congenital problem where the PUJ gets obstructed, and they can have quite gross hydronephrosis and scarring of the kidneys as well, although often this is an asymptomatic finding. Now there's lots of different ways of grading hydronephrosis, but I think going with the simple mild, moderate, severe, or none, some, and a lot is very useful. And in the acute setting, we're generally looking for really quite subtle hydronephrosis, so somewhere at the bottom end of the scale. Once you start seeing cortical thinning, that's much more likely to be a chronic process, and maybe due to long-standing lesions of the VUJ or previous bladder problems. But if you're seeing mild or moderate hydronephrosis, that may be a sign that there is something else going on further downstream in that renal tract. A couple of other cases we'll just run through. So this is a relatively normal shaped appearing kidney, but if you look at the echogenicity of this kidney compared to the adjacent liver, you can see it's actually very bright, and it seems to have lost that normal corticomedullary differentiation. It's hard to see where the cortex stops and the medulla starts, and so This is what we see in patients with acute kidney injury, so patients that have a medical problem, whether it's glomerulonephritis or acute drug-related nephrotoxicity or acute tubular necrosis and ischemia from being septic. This is what their kidneys tend to look like. This is potentially reversible appearance, but just be aware that a bright-looking kidney that may be a little bit swollen or possibly a little bit edematous can just be part of the underlying systemic disease process. This is another not that uncommon appearance. This is what we call nephrocalcinosis. This is a patient that has some sort of high calcium urine output. So we often see this in patients that have calcium metabolism disorders. Uric acid problems can also do this. So patients with gout, anyone that excretes too much calcium through the kidneys, whether that's from diet or genetic problems, can get this appearance where there's this outline of the collecting system in calcium. And then finally, patients that have end-stage renal disease, such as dialysis patients, will have these very shrunken, bright kidneys with often little cysts in them. They can be really hard to see sometimes, even because they blend in with the surrounding fat tissue. But that's what a chronic kidney in a failed patient looks like. Another quick case here. So this is a young, I think it was about a 14-year-old child who had a minor fall and landed on his left flank. And what we see here is, on the left of screen, a cystic lesion that's got a fluid level within it. So there's a black fluid, and then within it there's some more debris. Then when we roll the patient into the prone position, the fluid, that debris falls once again to the most dependent part. So this is a blood clot sitting within an existing hemorrhagic cyst. So this may be a chronic cyst that has bled into it, or we don't really know, we don't have any old imaging, but could be the cause of the patient's pain and hematuria. And another case here, this is the case of a 2-year-old child who was quite septic and unwell appearing, who was on the pediatric ward and wasn't really responding to the intravenous antibiotics that was being prescribed. And on day 3, this scan showed this appearance. And what you can see here is a kidney that doesn't look too abnormal. It's maybe a little bit edematous appearing, and there are a few little patches, but what you can see is under gyrotous fascia there's this free fluid here. There's a couple of differentials for that, but in the context of infection, this could well be pus, it could be blood, or it could be a urinoma if there's been obstruction and rupture of that collecting system. Hard to say, but if the patient remains septic, then you'd have to assume that that's an infective process. And another one that's not too uncommon, but just can be a bit of a trap. This is a transverse view sweeping from superior down to inferior. And this kidney looks really weird. It's really long, and this large, bright structure at the back is the vertebral body. You can see that this kidney crosses right over, and if you look closely, there's actually one collecting system here on the left of screen and another over there on the right. So this is a congenital horseshoe kidney, so it crosses the midline, and the two poles of the lower poles of the kidney are joined together and fused just in front of the vertebrae there. So that is a horseshoe kidney, which is an interesting finding and does have a few complications associated with it. Now, there is a sonographic approach to the acute renal failure patient. So if you're working in the ED or the HDU and you have a patient that presents with new renal failure and you're not sure what the cause is, it's nice to think of it the way we were taught in med school, but with an ultrasound, this is much easier. So let's start with the easy one, which is post-renal failure or obstructive uropathy. So when you look at the kidney, if you expect to see some hydronephrosis, you may see some stones in the kidney. And if you look at the bladder, you may see a very large bladder. If there's a urethral obstruction, you may see a big prostate, clot tumour. It's very rare for a patient to have bilateral ureteric obstruction, although this can happen, particularly with gynae tumours such as cervical cancer, which basically grow right near the trigone there. So that can actually happen. Usually we know about this beforehand, but generally these patients will have a normal heart, normal IVC, and that is how you diagnose and exclude a posterior obstructive cause of renal failure. Pre-renal, once again, the kidneys may take on that. They're probably normal in the early phases, but if it goes on for a few days, they may get that bright appearance, they get a bit big, a bit round. They may have an empty bladder if they're not making much urine, and the heart could be doing one of a few things. Could be hyperdynamic if they're hypovolemic, and that could have an increased ejection fraction, or it could be hypokinetic if they're in fact in LV failure, and that is the cause of their pre-renal failure. Now you want to look at the IVC and just get a bit of an idea of their volume. A mid-range IVC isn't that useful, but if it's really big and they've got CCF, then that's probably what's going on. Or if it's really flat and you think they're hypovolemic, then that's probably what's going on. The ultrasound is not particularly useful for diagnosing primary renal problems, although you may see that bright echogenic enlarged kidney. It may be a bit calcified, and obviously if they're not making much urine, their bladder will remain empty, but you would have already known that. Now we need to talk a bit about incidentalomas, because kidneys do contain a lot of incidental findings which you need to be aware of, and you need to have a bit of a plan as to how you're going to manage these. So we'll start with the one on the top left of screen. So this is a pretty round, small, hyperechoic, homogeneous lesion sitting in the cortex of the kidney and doesn't really have any color flow. And this is a very typical appearance for a thing called an angiomyolipoma, or AML. It's a very common benign renal tumor and generally doesn't really need any intervention until they get quite large. But if you see these, they probably do need to have a formal scan just to document and work out that that is in fact what it is, because renal tumors can look very similar. And that's non-urgent though. That can go off and have a formal scan in a couple of weeks and just put on the referral incidental finding, just clearing what it is. The top right of screen, you have this mass-like effect in the left kidney, and this is actually a normal finding. So the left kidney tends to have this thing called a dromedary hump in some people, where they get this big bulge in the mid-pole of the kidney, which looks like a camel hump, and this is completely normal. But if you slice it just the wrong way, you can look like there's a large tumor there around the cortex. And so if you're not sure, the best thing to do is to ask an expert and get a formal scan. The bottom left of screen, we have a very simple looking anechoic cyst, and these are very common when scanning kidneys, particularly in older people, pretty much universal. And if you have a good look, you'll see them all the time. Unfortunately, these can also present as RCCs. So RCCs often present with cystic lesions, so it can be hard to differentiate the two. And I think in the hands of a point of care provider, the right thing to do here is, if you see a significantly large cyst, then you should send that for a formal scan. Now the bottom right is very easy pickings. So this is a patient with polycystic kidney disease, and you're not going to mistake that. It's often a very large, lots of different size cysts, and the patient will probably have a family history. But it's important to know about them. These patients also need a formal scan to make that diagnosis, because it has implications for their subsequent follow-up and monitoring. Here's what we don't want to miss. So this is a non-simple cyst. So this is a cyst that's got a few features to it. It's not particularly round, it's got septations, it's got a bit of calcium in it maybe, and it's sort of distorting the architecture of the kidney there. So if I were to see this, this is one that needs to go off and have formal imaging, so, and probably cytology, because this is a renal cell cancer until proven otherwise. And so you just need to be aware that that's what they look like complicated cysts or solid lesions sometimes. Anything with calcium in it generally needs follow-up. So this one probably needs to go for a CT rather than a formal scan. So in summary, renal scans can be quite tricky, but get the patient on your side. Lots of positioning cooperation. Bladder scan's very easy, but looking for jets requires a bit of technique and quite a bit of patience. Beware of the pitfalls when measuring things. Make sure you're measuring the right thing. Remember that stones are tricky. It's difficult to identify stones, but it's much easier to identify those secondary features that twig you off to the fact that there's something obstructing that ureter. And think through the causes of renal failure and their likely appearances, and particularly post-obstructive renal failure. If you can find a big bladder, a hydronephrosis, then you've got a bit of an idea as to what's going on. And remember, there are lots of incidentalomas, and just think about what you're going to do with these, who needs a formal scan, how you're going to follow these up. By all means, talk to your friendly local radiologists or the sonographers in the department and get a bit of an idea around the urgency of these follow-ups. Alright, see you next time.